Good afternoon. It's 3 o'clock and I'd like to call the meeting of the Finance Committee to order. As our first item, please note the mission and vision statement as presented on our agenda. And I'd like to suggest a motion to approve the agenda for today for the Finance Committee.
So moved.
Right. Moved and supported. Any discussion? All in favor, please say aye.
Aye.
And opposed, same sign. That motion carries. And next, I'd like to suggest a motion to approve by consent the minutes from the October 2025 Finance Committee that were printed for you today and also sent out.
So moved.
Support. Been moved and supported. Is there any further discussion on the minutes from October 20? Hearing none, all in favor, please say aye.
Aye.
And opposed, same sign. Thank you. That motion carries as well. We have a presentation by Dr. Brashears.
Yeah, it'll be a verbal presentation, and then I'll tell you what I want to do. I was going to come prepared today with a slide deck and a presentation about what we're understanding about the fiscal year 2025 deficit. What I've elected to do is to go through the variables with this group, but do the full presentation with the full board at my director's report on Friday. Because inevitably, if you're a board member watching this and you're not part of the Finance Committee, you might have some questions. You might want to. So what I've decided to do is give you kind of like the big bullet points here, have some dialogue, but to reserve the right during my director's report on Friday to do the whole thing in front of everybody, because they're going to ask questions anyway. And quite frankly, as Madam Chair, you'd be put in the position to try to explain and answer questions at that time. And I'm just thinking that's a better strategy when we have major shifts in what we think. We talk about it here, but then the full board gets to see what's going on so that they don't just have to trust that you had all the questions for something like this. So that's what I intend to do, if that's okay. Originally, when I put this in the agenda, I was going to say, the truth of the matter is we're still finding out our year-end data from 2025. What we do know is that we have had a revised estimate and our deficit, our expenditures. We were thinking it was going to come anywhere between 1 to 3 million. We even added 3 million to the revenue line, which we'll go over later, to kind of made up for that. And what we're finding now is the current trending is it looks like it's going to be closer to 5.2. And there are certain variables associated with that that I'll go into some detail now, but more detail coming on Friday. The first is slight revenue projection to the worst on revenue. So less revenue than we estimated. And remember, revenue is based on a combination of factors such as the number of Medicaid lives in our particular region, in our county, and it's spread out regionally, and then encounter data that kind of offsets that. And so we have some revenue decreases, even though we had an increase in revenue due to the state kind of pushed out some money to us, the 140 million, you remember that? Mm-hmm. Still need the exact figure. So I'm waiting for an exact breakdown from the regional entity on the revenue side for both 2025 and 2026, which I'll also talk about in a moment. We had, our deficit lies in a couple of areas. One, contractual client care. So what is that? Autism, specialized residential, CLS, those major areas, and inpatient hospitalization continue to be the areas where our demand is exceeding the revenue we get, okay? And so during the whole year, we were in budget meetings looking at a way of tracking where we are on the budget. And so we'd meet as a leadership team and we'd look at expenditures based on what was billed out, and we'd kind of figure out where we're at. And for most of those months, we'd sat in there and we'd go, we're within our budget, The one thing that hasn't been tracked, and I found out it has not been tracked anywhere in the region, is the number of authorizations you have and then the corresponding expenditures with those. So we've been budget monitoring based on what was billed out and not what's projected based on authorizations. We put in auto in the middle of the fiscal year was a way to kind of help us feel that. And we're now starting to see the benefits of it. And I'm putting in place a different financial monitoring system that looks at authorizations and expenditures so we can see the trend data. And I'll go into much more detail on Friday. But that's one of the reports that's needed for us to get better tracking on, especially client care, that contractual things we don't directly provide, authorizations to true expenditures. And then you got to measure, well, what percentage of those authorizations did the clients use? So it's authorizations, how much did they use, and how much was kind of billed out. There's three areas in our financial monitoring that we have to strengthen significantly. I believe I'm going to have a report to do that within the next 60 days. I'm working with IBH, which is our contract guy that helped us with a lot of different stuff, the residential study, fiscal and other folks, to put together that. We asked the region and the regional partners if anybody has that, or if PCE itself, our vendor, has it anywhere in the state, and the answer is no. But when you think of it, it's the only way you can truly monitor where you are expenditure-wise based on authorizations. Does that make sense? Questions on so if you're not keeping track of what's been authorized or increases in authorization in terms of projected expenditures, it could hit way in the year, or the full year, or the impact it can hit far too late. You could be 2 quarters in and not realize that you're overspent from your budget on, say, CLS. So one side of it is monitoring, but I'm going to tell you, and I'll be able to demonstrate, that the expenditures on the client care side are all based on reasonable authorizations, a sound utilization management program to ensure that we're not authorizing things we shouldn't, the amount, scope, and duration of those authorizations being within limits. And this is purely driven on client need that we can't say no to. The revenue is not matching legitimate expenditures. And so the majority of over expenditures, we have about $500,000 or more on inpatient hospitalization. We have verified every one of those admissions were needed and not preventable. And so when you do that, you have trend data that suggests that, then it's a matter of looking at the utilization and having accurate pictures to let the region know. Like, where you're going with that. You're going to see that we have in our packet today for contracts, new contractual rates for inpatient providers. There's a couple in there. By the way, the region sets that rate. We don't. The region tells us, oh, by the way, your inpatient per days, because we all agreed to let them do that, is now this. It's higher. It's not like they send us corresponding revenue to match that. So anytime there's a rate increase that are needed, legitimate, and you're a CMH trying to manage it, unless there's corresponding revenue, you're always in a deficit and have to figure out how to prioritize by the most needy. This is true in residential, inpatient care. So the major drivers continue to be the things that we've been working on and kind of strengthening our process. Autism services, specialized res, which wasn't the biggest driver, CLS, group or individual community living supports for folks in self-directed arrangements. I'll talk about in a moment. That's gone up in terms of overall expenditures. Inpatient care went up. Here's what didn't go up. Everything in our control. We had a $1.1 million last fiscal year of savings due to not filling vacancies and managing the stuff that we can in our CMH. As a leadership team, we controlled all of the spending that we could control that's not related to medically necessary client care. And I'll be able to show that to the board, to the tune of salaries and benefits, 600, wait a minute, it might be 99,000. It's in another report later. 666,000 in savings, tightening the belt. We could have filled all those positions to match the need. We could have done that. Our directly operated system continues to work with, I say, bare minimum, growing very slowly to help control costs and not filling vacant positions. The other savings were other reductions we had in other areas that are in more of our control, which I'll be able to break down. But this board, and I'll make it, it's my life mission to let the region know, they know this, that the very things that we can control as CMH we have, and the things that are going up in expenditures is a medically necessary care for people we must put into those level of cares. I got questions, Michael, why do you approve residential care? Why don't you just say you don't have enough money and we're going to have to wait until we have more money? Simple answer, against the law. That's why. I'll be in orange if I do that. I don't look good in orange or in handcuffs. That is a level of care that if you meet that level of care and you've done everything else to prevent that level of care, you shall, not may, you shall place people and pay, what it costs. Same thing with inpatient, same thing with every Medicaid service we have, their entitlements. So our goal is to make sure that people are getting the right service at the right time, at the right level of care. And I'll be able to show you how we've strengthened significantly our utilization management process so that you will, at the end of the meeting next time, see that there's been at least 11 different changes we've made to strengthen that over the last year, which we've done. So we're sitting with the region, Myra, Nick was there, Anna was there, and we're trying to figure out first, how do you predict revenue? Okay, which there are massive swings on projected revenue every quarter when we meet with the region. And you'll see later in today's packet, last year's like the FSR that the region has, and you'll see massive swings in revenue projections, for 2026 coming up. You'll start seeing those. I'm convinced that we don't have a consistent manner to predict our revenue, which makes balancing the budget very difficult. But needless to say, we're working on that. But the major issues around the fiscal year 2025 deficit are the same issues as last year with some, it's the same areas of care that continue to see increased access. It's one of the reasons that the PQI committee, I show that access report every single month and at the full board. The door's wide open, folks. 80% of the people get in, even if you screen them, right? We were looking at a report this morning that 70% of the people that we evaluated for inpatient hospitalization got in. That's a diversion rate of only 28 to 30, 30% roughly. You can kind of go back and forth. Just think about that. It's the most costly per day service we have. And even with extensive crisis evaluation, guidelines, folks are seeking this care and it's growing. So the theme of this discussion is to alert you. I'm going to break it down even more specifically for the full board, but it's the same 4 or 5 expenditure levers that are increasing our expenditures. There's not corresponding discharge rates of people that we're not serving. Unfortunately, the biggest discharge criteria we have is death. Very few people, except on the MI adult side and maybe substance abuse side, kind of come in and out of care. Once you're in our DD system or autism system or family system as a family, you stay there unless you're family and you become an adult. Once you're with us in DD, really, I hate to say it, that the discharge criteria that's the most is either moved out of the area or death. So once we get somebody, they're ours and their expenditures could just go up, but there's not an increase in corresponding revenue to meet this.
Yeah, this is a quick question. This may be a Q&A question now. Is our length of inpatient stay pretty consistent?
We are the best in the region.
We do.
Yeah, so I'll be able to provide soon regional information on our inpatient. Our inpatient kind of program is the best in the region in terms of how we evaluate and the length of stay being shorter. That it averages, depending on the population, from between 3 and 10 days. Sometimes a little longer if it's complicated. Sometimes It's shorter, just if it's a rapid stabilization, but it's within the 3 to 10 margin. If I had to guess, if I was looking at it, we probably average around 5.5 days when you put them all together. When I did inpatient work years ago, the average length of stay for an adolescent was 6 months. They're there for a long time, right? Or adults too. And the level of evaluation we're looking on the inpatient side is how many of those clients that went into the hospital were new to us or existing clients. Because if they're existing clients, you can look at it as, okay, did we not provide enough care to prevent them? And we're looking at that data. The inpatient side, I'm not really as worried. It's really the cost of delivering services, the true cost of care for residential autism, CLS across the board, and how you manage that. Our board, our CMH is underfunding our residential network, and we just considerably, up to 20%, in some cases more, compared to our regional partners. I just completed a comprehensive residential study, rate calculator, and it shows we need a substantial increase in the rates to meet what the providers and I and the region have agreed to. That's it's a suitable rate. So I got to deal with that issue on top of it.
Are you getting support from the LRE to accomplish that?
We'll get to that in a second. But I just want to let you know that we did have a discussion with the region that showed our estimate to be too low, even though we thought, remember, Nick's like, let's just add 3 million. We'll get there, right? We'll be within this region. And we're like, what do you mean? And we're still double checking the facts because we still have stuff on the CCBHC funding stream. We're waiting for certain accounters to come in. So we're still finding out. But I am going to come prepared to the full board to go over that, all of these variables and what our plan is. By the way, we're still within the margin where the region covers it, barely. So like right there, okay? But it is something that's in the Internal Service Fund. You just don't want it to keep growing and growing and growing, right? Because sooner or later we'll be outside of that window of what the region's able to cover. By the way, that's our money in the Internal Service Fund. It helps to deal with these things, but sooner or later you run out of money if you keep using it. By the way, this happened to other boards in our region, Network 180 also, a lot more than what they had thought. The other CMHs either broke even or a little bit under their budgets, projected. We don't know complete year end, but projected. But I'll say it, I'm sure people are watching. It's my belief that the funding methodology model in our region, how much Medicaid you have, hurts Ottawa and Kent and does not hurt the other 3 CMHs. In fact, since the region changed the way it gives Medicaid, not the state, the region changed the way they disperse Medicaid in our region, Ottawa County and Kent County have been losers every single year. We've either broken even or been in a deficit. And it's my contention to continue to address that within the region. And I'll tell you about an email I sent on Friday in a month. Any questions on 2025? Same levers. We got some more digging to do on utilization management. Comprehensive report coming to the board, but it is in your packet later, and I'm going to get into it more, where you're going to see things for the first time, like in our control, not in our control, in the margin. And then you start to get the sense on our budget lines, what we're thinking is just a matter of utilization versus a matter of fiscal management. Because if it's a fiscal management issue, mismanagement issues, that's my responsibility. But if it's not, then it's what's the impact of that?
I'm a resident of Ottawa County.
Mhm.
If I come to CMH and knock on the door tomorrow and say, I need services, and you determine I need services, and you determine what's appropriate, and there's a cost associated with that, pick a number, $50,000.
Right.
You incur that expense by accepting me as a client and determining what my need is. You have to fulfill those services by contract under the mental health code.
Correct.
But you get no more revenue for doing
There's no advantage for me to serve more people. There's only a disadvantage. It's the worst possible scenario. cover all the expenditures. But here's the money you have to do it, and then you quote, manage it when it's underfunded. That is the true statement that you just said. You
Now,
know,
the other aspect of that, authorizations. If we consider an authorization to be a purchase order, when you agree to an authorization for services, you're basically saying that person is entitled to those services, assuming they show up, it's going to cost me the rest of the year X dollars. That's like a purchase order.
it is. And that authorization also says something even more important. The service is medically necessary.
Right.
So you can't change the authorization based on funding. You can't even base the authorization based on funding. In fact, that's illegal. You can't determine amount, scope, and duration of a service that someone receives based on the budget. You shall not do that. So once we authorize a service and we say it's 2 times a week, we have said that it's medically necessary. And that's not only complicated if you kind of like have over expenditures. What I worry about just as much is the underutilization of what's been authorized. Like say you can't find a CLS provider, but the authorization says you get so many units a week. That's just as problematic to me as we're overspending, because we're saying you're not receiving the treatment that we think is suited for your condition. And so I'm worried about that end just as much. And so our model of authorizations, I mean, you've all heard as board members stories of folks that can't find a CLS provider. And they go, I got all this, like Beth and our board, we have all this authorization. I can't use it. Can't find anybody. That's another problem we're dealing with. But you are correct. One of the unique differences of our CMH versus any other CMH in the region, maybe in the state, but in the region, is that we have more people in self-directed care by percentage than anybody else. 21% of all of our IDD adult clients are in self-directed care. And that's a whole different financial monitoring program. They get to pick the providers. And we have some clients in self-directed care that cost us by themselves over $250,000 each. And we have folks more in that camp than any other CMH in the area in terms of number of people on self-directed care and a number of outliers based on medical necessity of what their needs are. So there are no handouts happening. And if I think there was a handout, we went to an appeal and the judge says you can give it to them. It's no longer a handout, right? But I've collected this information and showing the region that if we were looking at a needs base, if our Medicaid was based on the needs of our clients and the associated cost, our Medicaid allocation would be greater. And that's what it needs to be focused on, is the 8% of Medicaid clients we are serving and what it costs to serve them. And as long as we're doing a good job with the management of that, which is the region's obligation to tell us, we shouldn't get penalized for having folks with greater needs. We had people moving to this community just to get into Benjamin's home. We had people moving this community just to go to Harbor House, just to have that flexibility. And we have a larger percentage of people per number than the CMHs in our area. And so this is an issue of where needs-based funding needs to be the day. And we used to have it here a long time. The region used to be that way, and then it switched many years ago. So just the number of Medicaid lives you have in your county. But I'm letting the finance committee know we have some work to do on our financial reporting parts, which are on the way, in terms of we are not doing a good enough job tracking what we've authorized and the possible financial impact of that. Our reporting has been what have we spent and what do we think we're going to spend, but not based on actual authorizations in the system. And we now have an EMR system with PCE that is very similar to everybody else's, and I think we can get there pretty quickly. And so I'm looking to be able to bring back a version of that to this committee probably in 2 months, so you can see how we're going to track it.
Yeah, but Michael, even if you can measure the authorizations, there's still things that are out of your control.
Yes.
So measuring the authorizations helps us do what?
Well, it helps us get a better barometer so that I'm not going, we thought it was 3.2 million and it's 5.
Okay.
And do you remember poor Amy used to come here from finance, she'd say, CMH is in a healthy position, right? And we forbid her to ever say that word again because we couldn't control the variables to make that true. And so we're doing like what we think it's going to be based on projections, and we need to tighten it up. And the biggest thing is the narrative and being out in front of it. So the first quarter, I can say, boy, at this rate of authorizations, holy crap, by the third quarter, we're really at $6 million, and I have to fight for more revenue and a different target. We were all caught by surprise when we were kind of doing the initial year end. And Myra, who's taken over, is going, how do we even know? And we would go, well, let Nicholas tell you all about it, right? But just because it's not in our control doesn't mean we don't have the obligation to manage it at the highest, at the gold standard, because we have to explain this. Because people could say, well, you're just authorizing willy-nilly. You're just, do you know there's no longer a tool that the IDD adult population, used to be the CIS, can use to determine amount, scope, and duration of what you would authorize? We're building our own. We're going to roll out a pilot of it coming up. Next PQI committee, you're going to see it. We had to build our own because the state doesn't have it and the region doesn't have it. So we didn't have any even initial benchmarks of how do you initially set how much somebody should get, besides the family saying, we need this. We had to work backwards. There's no utilization management tools on the IDD adult side, which is 40% of all of our expenditures or more. So we got to get that in order. So I've been here 1 year and 3 months. We've recognized this. It's taken a while, but we're building our own. We're not going to wait for the region or the state to do it. We've got to find a way to have equity of services so that families can go, you know, I'm talking, and they talk to each other. I talk to Mary Jane, and Mary Jane gets this much of this, and this person gets this much of this. And when I look at our loved ones, they're about relatively the same. I have to have a way of explaining that. On the adult mental health side, I can do this. I have the locus. It's a level of care determination scale. With specialized residential, we just built a rate system to do that and a decision tree to do that. The advantage is to help the people that are determining the revenue have as much information as they can, as timely as they can. Because if not, then I'm going to say, why am I managing the managed care functions for the region if they're not going to fund it? Remember, we are delegated that from the regional entity, how to manage amount, scope, and duration. Other regions, the region does it. And if I'm not going to get enough revenue, you might as well do it then, region. And then you figure it out, which I don't want to have happen, but that's the natural consequence of not giving your partner enough revenue. On Friday, I sent an email saying that to the region based on discussions that we don't have $2 million in reductions for last year. And if our revenue goes down in 2026, and they're already looking at that and the impact of that, then there isn't $2 million, $3 million to cut. But maybe we could give back some MCO functions. And you can do it, which the region would have to vote and everybody would have to agree. But it's more the principle than the realistic. By the way, that's what the state wants to do with this new restructuring. They want to take all this, give it to the region, and we're just providers. I think that would be a disaster because we're keeping track of the local needs.
Because they'll take a closer view of what medical necessity means.
Yeah,
And we know what that, and we know what will happen in that circumstance.
yeah.
Many of us have been through medical procedures, look at our EOBs and see how many of those EOBs are rejected and rejected and rejected until they're finally dealt with. But I'll get off my.
No, but that's it. But Madam Chair, that's why I'm elected to educate the committee, but then say, all right, I want the full board to see this in living color so they can ask questions. Because we're still figuring out, I'm looking at this side of the aisle, what the real, we still have things to clear and all this stuff, but we know it's more than we projected. And I know at least the big levers and what I want to do about it now, but I don't have the final numbers. And I call this the November surprises. I don't want any more November surprises. Last November, go to the wedding, come back. I don't have a surplus, I have a deficit. This November, she goes to Europe, comes back, we have a deficit. We're forbidden to leave the state in November. Right. But it's because of how we all are in the region, in the state, tracking this. And there's got to be a better way to be closer than, you're 2-3% off, you're millions of dollars off, right? But remember, we're still within the ISF thing, right? We still cost settlement with the LRE on these issues. We're going to be okay on that end. But if we don't, if we know that this is going to continue and next year it's a $10 million problem, then the region will run out of ISF. And so I have to know that quick. I mean, go ahead.
Talking about next year.
The year we're in actually right now, I should say, yeah.
But based on what you have said, we know this year, roughly what's going to happen. It's not going to get any better next year,
I
is
think
it?
it worse.
Yeah, because your fixed expenses are going to be the same level, if not higher, because of cost of living increases.
Yeah.
Adjusting salary scales, and every other expense you're faced with. So your fixed expenses are going to have to increase to provide the same level of service that you're doing now with staff.
And with less revenue,
Yeah.
one of the things I didn't put on the agenda, but now this has turned into the budget as a whole. We were already notified by the region and meeting with us that we're expecting a 4% decrease in Medicaid revenue for this year for Ottawa. That's 3 times larger by percentage by any other CMH in the region. And the reason why, and that's about 2.2 million? 2.2. And I've said, okay, the jig is up, because just because Ottawa County has a decrease in the amount of people that's on Medicaid, and there's this other thing they're recalculating, which I'll get into, right? We're going to have a decrease in Medicaid revenue projected by 4%. And I've already said that that's not sustainable for Ottawa County. They need to send to us a detailed explanation, because I'm going to have to get our legislators and everybody else involved, because we're being disproportionately hurt by the way that the revenue is determined. We serve the same 6 to 8% of Medicaid recipients as every other CMH in this region. They have the most severe forms. So that means the state, and you've heard me say this before, I'm going to make it a t-shirt. State actually assumes that close to 92 or 94% of people in Medicaid will never show up here. So they're not funding us to serve the Medicaid population based on, say, mental health prevalence rates. They're just saying, well, this is what you got, this is what you need. Our 8% of the people we serve are more expensive than, say, another CMHs are. And so if we have decreases in Medicaid enrollees in Ottawa, that's disproportionate to other counties in our thing, we see more of the revenue not come to us. And I will be fighting that, but I'm waiting for an explanation of how they officially got to. I mean, they tried to tell me, but they couldn't tell me some aspects of it. But it looked like I think it was like a 4% reduction. That's huge. So if you got a 5% increase and a 4% reduction, now you got to deal with a 9% problem, right? There are answers, by the way, for all of this. It's not panic, it's information, just so you know. So the revenue issue, we already have legislators on the county saying we're going to try to get a specific allocation to Ottawa. We'll try, just to bring in more revenue. But that's what we're dealing with in Ottawa County. And once I get the detail on the Medicaid, and they're just projections, you can go all the way to the end of the year and they could be wrong in their projections, and more Medicaid to come in. But they did ask us to submit another spending plan, the region, for this year. Like, how can you spend 2.2 less? And I basically wrote, we'll keep doing the things that we've been doing. There's no way to actually reduce that much. It's about revenue. And so that's where the discussion has to be. And I wouldn't say it was about revenue if I thought there were a lot of low-hanging fruit here. But I've been here long enough to know that we're actually very efficient with very few people to do it.
I have a suggestion.
Well, please.
Tell the region we will send them 9% of our consumers for them to take care of with the
Okay.
budget.
Yeah, now the region's been very supportive, just, in all these things.
Yeah.
Mary Dumas, the CEO, the CFO, they understand. What I want is a regional strategy to get more revenue from the state, and I intend to be saying that. So the regional entity staff are not going, well, good luck, right? They just know they're gonna run out of money too. Like, so we're partners in this, but I need them to pivot quickly to say, dear state, there's just no way this is sustainable, which is what we've been saying as a system for a long time. And that's why I could never figure out why people are falling over themselves to manage a system that's underfunded. They're all falling over each other,
Michael, what was our deficit last year?
Yeah, I think we ended up around 4. Yeah, well, no, 24. Like, yeah, I think we ended around 4. What did we settle for? Yeah, it was less than that. We thought it was 5. When it was at 5, and we started doing stuff, right?
Michael, correct me. It used to be that Medicaid eligibles included 2 classes of people: the disabled, aged, and blind, the DABs, and then the TANF, people who were on Medicaid for financial reasons.
Working poor.
Right. And the TANF group is basically, I would assume, around the state, pretty much that same 5% of the population.
They're much more in this county. In this county, we have a disproportionate amount of TANF versus DABs, and that means our rate's different. So Medicaid equity now, it does matter where you live, evidently, because the way that the Medicaid is sent to us is based on DABs and TANFs. More DABs you have, the more money you get. The more TANFs you have, it's less money. By the way, the benefit's exactly the same. There's no such thing as like, oh, you're in TANF, here's your Medicaid benefit. It's the exact same benefit you're entitled to. And that's been my argument, like, well, it's the same 8% people. Doesn't matter if they're DABs or TANFs. They're all severe. Now, Ann and I were talking this morning with the leadership group. We have a lot of people that keep falling off Medicaid, and trying to get them back on has been difficult. And that hurts us both on now their general fund expenditures because they're not Medicaid, and it lowers our Medicaid encounters, how many Medicaid services we provided, which is another variable the state uses to figure out how much you need, but it's not the main variable. So you have a double whammy when you have people falling off Medicaid and you have a disproportionate amount of people on TANF versus DAB. And we have that in the county more than anybody else. So that hurts us and this funding mechanism. Did we find out? Yeah. Right.
So, when we reported, I want to say it was 4 months ago, back to the board, that we felt we were in a healthy position and some of the deficit. What you're going to present will explain what happened between then and now.
Yes. And how even we're still within the margin of the ISF code. So we're still, it's just more than we thought, and we're still verifying it. But once we knew it was going to be more than we thought, we had to do a deep dive on our end and say, okay, what happened? And but a lot of it too is it's revenue projections too. But the answer is yes, we'll be able to reconcile what was said at meeting A with meeting B. Right? Hence why I want to do it for the full board. Instead of here, you could go, oh, thanks for telling me. But then Jordan or somebody else goes, well, wait a minute. Didn't you yourself, Madam Chair, tell us last month? Because remember, it's you talking to them too. So that's why it's like, okay, we got to get there. It may be far better than we think once we get everything closed out. But we have an obligation to tell you it's more than what we think. It's these levers. We have an obligation to say, here's what's in our control. And you'll see some of that coming up. And it's 1.1 million that we did, which is pretty, that's impressive. Okay. And what the plan is to deal with it in the future is kind of what we're dealing with. So instead of going through 45 minutes to an hour of a presentation here, I thought I'd introduce it, cover the main points, and then give me a little more time to put it together so I can be very succinct with it.
Any other questions for Michael? All right, thank you. That's a big task to pull that all together by
Yep.
Friday.
Oh, yeah.
Is there any old business that we need to cover today? All right, then we'll move on to our new business items. Update on the regional residential rate calculator. Dr.
Yeah,
Marshall?
okay, so here we go, right? So we completed a year process. I think it was about a year, right? Krista? Yeah, okay. And we developed a new residential level of care system. We created a residential decision tree, meaning we asked certain questions and which level should they get in. We met with all of the providers, got the variables on the true cost of care that we felt were allowable. We developed a residential rate calculator, our own, which I've kind of shown here before. We put, I'm getting to the regional part in a second. We put all 200 plus of our residential clients through the rate calculator, came up with what the rate should be based on that, met with all of the providers to verify if we missed anything, and we got to that point. So then the region at the same time started their own process based on our work to develop their own residential rate calculator. So they've developed it, and wouldn't you know, it looks almost identical to ours. They actually have a couple of other variables in it. And so last Wednesday at the Regional Operations Committee, which has the CEOs, the region unveiled their rate calculator, okay, and said, what do you think, CMHs? And of course, I'm like, looks familiar, looks great, okay. There are 5 members in our region. There's Kent, West Michigan, West Michigan has Oceana Lake and whatever, right? And then you have Allegan, which is on point, and you have Health West, right? So Network 180 in West Michigan said, great calculator, don't have the time right now to prioritize that. They didn't want to bring all their folks through it and determine the rate. So the region couldn't get all of us to agree to implement it immediately, but that's what I intend to do. I intend to take the regional rate calculator, put all of our clients through it, compare it to our rate calculator results, get the difference, and then tell the region how close we are. Because what the region has done through the rate calculator development is given us a way once and for all to say, here's what the specialized residential allowable cost should be and the rate should be. So the first time we have the potential region-wide to say, here are all the variables, compute them with this. If you're not paying your provider network at least this, you should raise the rate, which is exactly what I intend to do. Now, Dr. Bashirs, how are you going to raise the rate, which in our system it'd be a pretty significant increase if it's even close to that. It'd be a couple of millions, like $2-3 million to raise the residential rates. How are you going to do that with a deficit? I'm going to address the region on that these are the rates that are needed to sustain the network. They're not, well, they haven't had a rate for a while. Now, you may hear stuff today from a provider, but I have providers waiting, like if the rate doesn't get increased to this, and you're not going to use millage to supplement it, we're going to be in the same spot we were a year ago. And it's unsustainable. So the update on the rate for the region is a good update. They adopted the same philosophy we did, went through a similar process. They used our work as a foundation, which was good. And now I intend to figure out, based on the region's rate calculator, what our residential rates should be, not maybe, should be. And then the rest of the region's going to need to do that. And the region's going to have to go to the state and say, we're underfunded by X amount for residential services. Because I can't imagine they'll say, well, everybody increased their residential rates and you're all in deficit, so we'll have to do something, either raise revenue or reprioritize how the Medicaid is shared within the region. And so I'm just letting this committee know that I think that's good news, and it helps us address the need to validate the need for us to increase our residential rates. Now, we already did for Harbor House, if you remember. in July, we had an emergency rate increase, which is part of why some of 2025's budget was higher. Okay, it's one of the variables. Because we had to do, they had to do for 30 individuals, an emergency rate increase or lose the placement. Now, any one of my providers could say that to me, but they've been honest of like, we're hanging on, we're hanging on, we're hanging on. So this is a bigger issue than just Ottawa, but I'm very happy that the region followed through, developed the rate calculator, used ours as a foundation. And I intend to quickly, within like the next week or two, do a comparison. So that when I come back to you all and say, here's what I think is needed, and this is how I have to address it with the region, you'll know it's based on the region's validation that we did it right, and not just our own.
Do our regional partners give us any idea how long it would take for them to get on board?
Some of it was, I'll be very blunt. I know it's a public meeting, but I'm just going to tell you.
I'm gonna ask you.
So some of the partners said, listen, we don't have the ability to prioritize this right now. And in fact, some of them said, if the regions are restructured, we won't be dealing with rates next year anyways. Somebody else will.
Thank you.
Here's what I said. We have an obligation to the people we serve, period. I don't care who's managing the system. If the level of care cannot be maintained, until somebody tells me otherwise, it's my damn job to make sure that that service is maintained. And I understand it, deficits, all this other stuff, but it's a shared risk model, not a total risk model. We share the risk with the region and the state, and somebody's got to tell them the true cost of the care so they know how much money we're all at risk for, instead of stay in your budgets at all costs. But that was the reason, and I can respect some of that. I mean, one of our partners, West Michigan, already have higher rates than we do. They're like, I already got higher rates. I'll tell you right now, some providers, if they discharged all of the Ottawa County folks, you're gonna hear about it, and got other counties, people in there, they'd be fine. They'd be fine. It's our rates that's an issue that has to be dealt with, that has more of an increase needed because of our inability or choice not to raise Medicaid rates, use millage in the stead. And we now have a higher mountain to climb. So some of them are like, yeah, do the rate calculator because I'm already there. Some of them said, I can't prioritize this issue. For us, it's Mayday, as far as I see on it. The residential emergency is not over. The way to solve it is almost there.
So are we doing a
Thank you.
comparison with every one that you've already, that we've already gone through
Yep.
our own rate calculator and then looking at that
Mhm.
with the region
That's right.
calculator? And we're going to see what the
What the difference
difference
is.
is.
And if they're like, because the goal is, if the region says that their new rate calculator, that's based on ours, which is good news, are allowable rates, then, and should be the rate, then at a minimum, our rate should increase to that level. If there's a way to go after that, we can address that over time, and the way we can do that. But I got to see what the difference between, because there'll be some people in our system that the regional calculator will benefit more than ours, and vice versa. So you want to use the regional rate calculator because the region has validated their process and said this is allowable rates. Where before they're like, you negotiate them, CMHs, any way you can, and have them rob Peter to pay Paul. We don't care how you do it. Just you manage your system. And over time, that's led to disparity on the strategy and how each CMH funds all of their rates. As you know, if you're in PQI, I'm doing that for outpatient therapy. The same process. It's the only way I know how to do things is through a center of excellence model. Is what is the true cost? How do you get there? But yes, that comparison's the point. But I want to do it quickly because I don't have time to wait another month or 2 months to know. The providers, some of them signed contracts this year knowing that we're going to be dealing with the rates. The rate ranges were approved, but they haven't seen the increase yet for their existing people, and time's ticking. In fact, I found out one thing, Nicholas, that one of our providers didn't submit their billing for the last month because they were like, well, which rate am I using? And okay, so well, don't do that. You got to submit your billing, right? We're like, well, is it the new rate or the old rate? I told them in the meeting, but that's the issue. People are waiting. So I think it's a good update on this. This is good news that our process was deemed valid and replicated at the regional level. And now I have to do a gap analysis and show the difference and get moving. Because you already approved the rate ranges. Now I have to say who falls where. And that's why we did it that way. When you guys approved our level of care and our rate ranges, all of our rate calculator, we got people in the ranges that we think they should be in. And validated by their provider and or their guardian, if they have one. So that's what that is.
Thank you. And then we'll look at attachment A, the amended, renewed, and ending service contracts.
All right, here we go. Bill, you can jump in if I mess up. So just so you know, we have a committee that meets, that Bill leads with us, and before a packet is sent out, we all meet. Programs that are requesting, or if we have an amended contract, we meet, we go over them. I ask questions. Sometimes I'm saying this is not ready for prime time. It's got to wait till the next board meeting, or what's going on here. So just to educate the committee that we have our own group that meets every month to go through this. And so they get vetted by a group of people. And then I'm in that meeting, or if I'm not there, Anna's there, we're both there. And we're kind of going through this, and Bill runs that meeting. And I mean, it's a newer process we've been doing for almost a year, but I think it's really helped this. You know, staff kind of know like, oh, you got to put in your request for an amended contract, or Bill's saying this one's up. So there's a lot of vetting that happens before you get it. But even when you get it, we can still miss stuff. So if you hear us in this meeting, go, oh yeah, we missed it, but I don't think there's any in this case. So the group that you're looking at here for renewals, a lot of them are hospital contracts. So the first two are hospital contracts. Inpatient agreement, which we don't negotiate the rate, right? ARC of Michigan is for independent facilitation. It's a renewal of that. Independent facilitation is anybody can have an independent facilitator run their person-centered planning process. So yes, we pay people to run the meeting, even though we can run the meeting. It's the choice that people have to do that. So we have a contract with the ARC to do that. It doesn't have a lot of utilization in it, but we have to have a contract in it. There's not that many that actually utilize it. That's why the contract amount is like 50 grand, you know, remember, we serve thousands of people that all could do it. Contract 4 is a renewal of our services for deaf and hard of hearing services. So that's a renewal that we have. And none of these had a rate increase. That's why they're just renewals. So that is what that is. Locum tenens, I'll get to the, actually number 5 on that is it's the help desk. It's a contract to help us manage our help desk. And I went at this pretty hard at our meeting. I'll be honest with you, like, why don't we just do it? Well, why do we need a company to help us with help desk and we have a help desk? Well, this helps us with our real CMH specific needs in our systems. So it's not the traditional county help desk that if you're part of the county, there's a help desk. So you can say, like, Sylvia's laptop's broken. This is dealing with stuff related to our system or EMR system and learning that. So that's what that is. It's not a huge amount, but I was kind of finding ways to not spend money, right? So that's something that I've been told by Tony, our IT person, that's essential. And he went through it with me, and it is. And I know that Nick is saying, yes, please.
Use it.
Yeah. It's a small amount, but still. And then locum tenens, this is a contract with Dr. Muhammad. Because there's so much angst in the system, one of the things I wanted to do was limit the amount of locum tenens or contract psychiatrists we use. We actually did that. One of the expenditures from last year that went down was locum tenens. It went down by $110,000. We kept Dr. Muhammad on because as the providers will tell you, he's been phenomenal. And quite frankly, it's been very difficult to find a psychiatrist to hire with IDD experience. It's not my intent to keep this contract forever. But until I figure out what's happening with the overall system, I want to maintain the connection that our clients have with this psychiatrist and their families. This guy's making calls after hours, calling group homes. He has been phenomenal. And now I'd like to hire him, but he doesn't live in the state. And when you try to buy out that contract, it's very expensive. So this is just an extension of that to keep that going.
It's a huge problem with care.
Yeah, but I'll let you know, we did have a reduction. It's on what we had in control from last year, about $110,000 in the use of local temps. We hired our own staff, so one could say, well, you moved the expenditure to another side, but no, it's helping us deal with our directly operated clinics, which, by the way, we don't increase staffing when there's an increase of clients. Right. And so that helped us beef that up, especially family services. So that's what that one is. I just kind of go through them all. And if you have a question, then Holland Community Hospital, another inpatient, Pine Rest, another inpatient. And do you remember when I was talking about, we don't negotiate those rates? I wish Bill did. I think you'd get us a better deal, Bill, if you did that. Right. I mean, the guy that does it, the region, is great. But we're told, do you agree with the negotiated rate? But again, we are not giving additional revenue for increases in the inpatient rate, and they never go down. So when you think about the model we're in, wait a minute, I don't even control the rate, and I have to manage that budget? So it's something that if you're going to do at the regional level, if there's increases of expenditures due to the rate increase, I'm going to start keeping track of how much of that was an impact. And I'm going to say, all right, we had no control over that. We go to residential providers all the time and say, keep the same rate until we can work it out, or other providers. With inpatient, it's pay it or else. And so I'm going to be keeping track of how much of an impact that increase in the rate has had on our overall expenditures. And not just utilization going up. So I can start knowing, like, things are out of control, things that are not in our control. Is the inpatient rate in our control? Not really. The region negotiates it. I could say no, I guess. But the hospitals know that, okay, out of the 5 partners, 4 of them just agreed to this rate and you're not. Guess what? They're going to say, no deal. Your whole region just agreed to this. So it's better to do it. And I will say, the person, is it Jim McCormick? Who does it? Jim McCormick, if you're listening, does a great job at the region with this, but it's still an increase. And there's still not a corresponding increase in revenue. Right? But that's what those are inpatient contracts.
But your rate with Holland Hospital, you negotiated, right?
Kind of. We negotiated a deal to buy some beds for them for utilization, but the actual rate is negotiated at the rate. And we've kind of had to look at that deal, like, is it working for us? Because sometimes we've had a bed to hold a bed, and we weren't allowed to put the person in it. So why am I purchasing something that I can't use? And then all the acuity's too high, whatever. So I know that Anna and Tim and the team are getting together and renegotiating that one a little bit. Because we did have, at the end of last fiscal year, our little experiment of that needed some revision. So we had some expenditures that were related to that arrangement that we had to change the arrangement. Because we had too many beds that were just left open that we were paying for that we couldn't utilize. And it was always based on the acuity of the client. We needed a locked unit bed versus a non-locked unit bed, or a PICU bed, right? So we're working on that. But that is one of the things you'll hear on Friday as one of the variables in inpatient. So we negotiated access, but not the rate, if that makes sense.
Yeah.
Hold the bed open just in case we need it before everybody else gobbles it up, is what I did. Because everybody wants to be in. I mean, they don't have a problem with filling beds. Any of the psychiatric hospitals.
Models, people full.
Yeah, I mean, they're like, who do we not serve? You know, and the answer is anybody with an adult with a developmental disability, pretty much. That's who they not serve. So, and they're working on it, but good luck, right? So those are those.
You want to do these separately or together?
Well, I think do I have to do the new ones first, or you guys do those in phases? I forget.
Yeah, we usually do, this
Yeah,
first
so-
and we approve the motion,
Yeah,
the
so
motion.
the consent
And then
motion for all
move on.
those, yeah.
Okay, so is there a motion to approve the November 2025 amended and renewed service contracts as presented and forward to the full board with a recommendation for approval? And that's our attachment 8 that we just looked at. Support. Moved and supported. Any further discussion? All in favor, please indicate by saying aye.
Aye.
And opposed, same sign. That motion carries. And now we'll look at attachment B and in the same way, which are the.
So we got 4. Okay. First 2 are autism services, expanding our array of autism services, and you can and those are all Medicaid funded through the autism program. One of the things that fell off our chart, you can see it on the individual pages, but I think what fell off our chart was the funding source. Oh, no, nope, I lied. It's right there. It's the last one second to last on the right.
Yep.
Okay. So as you know, autism services continues to be an issue. We have contracts to deal with capacity issues. And, the state did give us a little bit more money for autism services, but it's not matching the increase in utilization. So the rate we pay for that, there was some state changes made in 2025, and they gave us revenue to increase that, but the utilization's still going up on that. And as you know, in our access reports, once you make it past our screening in autism, you're pretty much accepted after assessment. I think our family services for it was like 90%. So once you get past the screening and you get an assessment, you're in. So those are the first 2. Then we had talked about at the PQI committee, the need to continue to look at our outpatient therapy situation. So Rise to Renew. I don't know where they come these names, but they're pretty cool, right? And we've seen the need to increase our outpatient providers of outpatient therapy. And if you're at the PQI committee, and you'll see at the full board, there's reasons why our network is shrinking. People are actually getting out of business. And so what we've been able to do is convince some people that were leaving an agency to become independent practitioners and take our folks. So you're seeing a lot of those. They know the clients, they have the relationship with the clients. And our staff were able to work with them saying, well, I know you're leaving this company that's getting out of this business. They're like, we'll do it though, I'll do it still. And so some of that is that. And you'll notice in that one, you'll see the column where it says directly operated cost. Please remember in our directly operated costs, you'll see this versus this. It includes all indirect or non-face-to-face time. One of the biggest challenges for outpatient therapy contracts is that we give no benefit for the work outside the therapeutic hour. Our staff, they know they have 2 to 3 hours of work outside of each session, coordinating stuff, doing this. So unless the outpatient rates go up, there's no way for us to pay for indirect time. So I put that comparison in there, not to say, gee, it's an identical service, because our expenditures also include time that's not with the client, where their rate isn't. That makes sense. Mm-hmm. But we need to expand, and this is for Medicaid. This isn't for CCBHC. This isn't for general fund. These are people that meet our eligibility for Medicaid that need outpatient therapy in family services or adult services, primarily family services for this one. And the last one's a different thing. So that's what third is to expand our outpatient therapy array. And it's due to a loss of providers. We've had certain groups, like Bethany has told us they're no longer going to do that service. And Samaritas saying they're restricting what they can do. And a lot of it is capacity and other issues, but some of it's the rate, right? We're blessed in Ottawa County where we have a wide variety of partners, but the rate is becoming an issue to maintain that network. The last one is through our Systems of Care grant, SAMHSA grant. And if you were at the PQI committee, we did a whole thing on the Systems of Care grant. And one of the things was the parent cafe. And this, if I have this right, Anna, see if I got it right. See if you got it done right in my head. So we used to directly operate this under the grant. We used to do it. And it's a cafe where families can get together, education. They call it cafe because it's that feel, right? What we have found is it's difficult for us to directly. So we decided to have one of our contract providers do this piece for us under the System of Care grant. And this is what this contract is to move it from directly operated to contractual under the grant. Did I get it? All right, good. And it's no additional money. It's covered by the grant. It's just who's doing it, us versus a contract provider. And if you weren't at PQI, you can see the packet. There's a presentation that talks about this in there for System of Care grant. I think, is there one more? Is that it? Yeah, and that's the new contracts. And you can tell our new contracts are really focusing now on expanding the service array or replacing the service array, one of the two, or just the amendments are just increasing it. So we're really making sure we're not growing without the need to have to. And that's why our directly operated system that might seem expensive having CMH staff in it, it allows us to absorb an increase of people without necessarily increasing caseloads. But over time, that becomes problematic too, right? You get high caseload. But it's because of our directly operated system that we're in a better position. If we were like other boards that contracted out everything, you're constantly just dealing with rates and who's available, and you have no control over evidence-based practices and the quality of care for certain groups. And so when I put that comparison there, I don't want you to think, gee, we should just contract out everything, right? We did a study many years ago. I repeat this story all the time, but it's worth repeating now. Where I had Dr. Lubers say, all right, Dr. Lubers, what if we directly contracted out all therapy services instead of us doing some of it? He comes back with the results and he goes, good news, you'll save a fortune. Here's the cost difference. Bad news, no one will get served because the amount of people being served, like the no-show rate was so high that they only averaged 1 or 2 visits versus when we did it, they averaged more. He goes, yeah, you'll say the managed care companies would love you, but your clients won't get any services.
Because we'll follow up.
That's right. So we have a balance on purpose. But we also are able to control vacant positions when we can and put hiring freezes. I think, Anna, I'm going to have it ready for our next meeting, but I think of all the new positions that we wanted for the last year, I think we have like 6 and we filled like 2 of them or something like that. So we held off even on, you know how hard it is to get these county commissioners to approve new positions for us. And then once we got it, we didn't even fill them, right? We needed them, but we didn't fill them. And it's a provider network can trust us when we do stuff like that, when we can't give increases, versus when we give huge increases to staff, fill all the vacant positions, you lose credibility. And in this county, we have not. We've been dealing with union negotiated increases, controlling our vacancies to our best of our ability, to the tune of close to 600,000 last year. So I'm happy about that, but it comes with a cost. High caseloads, not meeting the high increase in demand. And so that's why the game is revenue. And we got to focus on that, which in the controlled expenditures the best you can, and then use your ISF, your Medicaid savings for what it was designed for. And so that's what we've been doing. And so from a budget standpoint, it's not like we're in an unhealthy position. We're just not in prime optimal shape. Is how I would put it.
Michael, can I introduce a rabbit hole here? At the PQI meeting, we had a discussion about the fact that we had providers for mental health counseling that were bowing out of providing service because they said they were losing money and they couldn't afford to do the services for the rates we were providing.
Right.
And the reason for that is we were asking them to share the risk by saying, we will pay you X dollars per encounter. And they were saying, well, we only get paid if the patient shows up. If we have a 30% no-show rate, our clients, our counselors are sitting there with a vacant slot with no revenue for that time slot because
That's
the
right.
person didn't show up. We
Right.
can't bill you for no shows. We
right.
can't bill you for time we spend on the phone trying to track them down to get them to come in. Now, we know our staff is, we're paying them for their efforts. And their efforts might include tracking the consumer down, saying, what's your problem? Do you have a transportation problem? I'll come out and get you. I'll arrange for a taxi to pick you up and bring you here.
That's right.
Whatever it takes, we try to get the customer in the door so we can provide the service.
Mhm.
So it struck me that, and you had talked about needing to increase the rates for these
Sure.
independent counseling groups so that it would cover some of their overhead for non-billable time.
Mhm.
And it struck me that that's sort of like the CCBHC concept.
Mhm.
What we're doing in CCBHC is we're on a fee for service basis,
Mhm.
but we're also given a stipend to pay for some of the infrastructure to get the program in place and get it operating. And then there's a risk reward benefit. We're paid enough money that if we're 100% utilizing all of our staff in CCBHC for billable time,
Mhm.
we wind up having more income than our expenses,
Mhm.
and we get to keep that. So there's a profit
So
motive.
you see the relationship between
Yeah.
outpatient CCBHC. And here's what we've done. Remember you all authorized the use of one-time millage last year?
Mhm.
We picked providers that do outpatient therapy so that we can convert them into DCOs on the CCBHC side. So we use millage to set them up. And guess what? They're now in the process to be able to take Medicaid clients and we get the extra payment, and you don't need millage to do that. Same thing with targeted outpatient that we're talking about. We're going to target when we want the outpatient therapy to be provided by us and by them. And then in a very targeted way, ask the question, is this a CCBHC type of benefit program? Could they turn into DCOs at the same time? So you're correct on the potential impact and those forces being counterproductive towards each other, right? If I'm following you.
Yeah.
And the strategy is, while we're involved in CCBHC, the more providers that we want to contract out to do the service, not directly operate, the more they have to be on the road to become a DCO, especially on the Medicaid side, because we get an extra payment. And that's how we're going about this. So we may have to stand up some of these non-millage funded outpatient programs to get them ready to become a DCO on the CCBHC side. And it takes a while. You can't just call the state up and go, hey, Arbor Circle, we want them to be a DCO. They make, I look at Anna because she jumps through all the hoops, jump through all of these hoops to get them approved. It can take months. So we're going to get these contracts in place with Medicaid, get the rate right. And then guess what? Figure out which one of these groups are best to be in our CCBHC machine, as I call it, to help offset the increase in rates we just did. Now, some won't make that. Some are serving people that are not CCBHC eligible, right? Maybe some of the kids we're seeing and all that stuff. But that's the strategy. And if CCBHC goes away, because remember, they could renew this thing in 2027, I'll at least have the infrastructure in place to deal with the fallout for Medicaid services or GF if we had it, or millage. So it's about a strategic plan of only using outpatient providers to meet a very specific need that we don't want to directly operate. And that's kind of how we're all looking at it. And we should start seeing those converge. So like City in the Hill, for instance, we gave them millage to do little City in the Hill. We gave them millage to do some outpatient services for us. Well, they did that. Next thing you know, they got a Medicaid contract from us. Right? On top of that, to see our Medicaid folks that we would serve, not the moderates, right? Well, guess what? We're looking at them to be a DCO to serve the moderate folks that could come in there. And sooner or later, there'll no longer be the need for millage for them. We did their job, stood them up, and they became a provider that can pay for itself with units that they provide. CMNOP, I can't say it all the time, right? CCBHC goes away. We still have a Medicaid provider that's used to seeing the clients, and just straight Medicaid is paying for it. That's the strategy. Who gets hurt the worst in that model? Folks with general fund dollars. We have to keep working with that maybe the millage could help if we have the millage. One of the reasons why we need it renewed, right? So I'm planning for all kinds of contingency. One, the full collapse of CCBHC in 2027, and to get people set up into CCBHC just in case it stays in place and it helps us control our risk with it. And I'll tell you, it's like all these plates spinning on sticks, right? Which one falls first? We're preparing to know the impact. Because the system has so many variables right now. You have Medicaid health plans doing services, millage, CCBHC, mental health, right? Any one of it's a four-legged stool and not a three. We're sick of hearing three-legged stools. So it's a four-legged chair that any one of those legs get pulled out, the whole thing has to be redone. That's what we're preparing for. I ain't waiting to see what people make up their minds. We're planning for all contingencies and creating a network that serves folks regardless of the funding stream. But it should help, Tom, with that tension that you brought up of like, geez, some of it could be counterproductive. You're doing it here, but you already said you can't pay them for the indirect time, so you're going to increase the rate. So how's that all play? Because we're setting up for 2 or 3 different contingencies with an outpatient network from Medicaid that's going to be needed in addition to us, because we're focusing on the most severe on our teams. And you come in here, it's high. I went like 8 minutes. Is that too long of an answer? No. Did you get it? Yep. You see what we're trying to do though, and I'm looking at Anna because it's a delicate ecosystem. We have to plan for contingencies that we have no control over. But the goal is have enough providers to serve people regardless of the funding source. And so it looks counterproductive at times, increasing the rate over here. You're not doing anything over here. Well, yeah, we're contingency planning. I look at all the contingencies. What ifs? I don't know if they're going to renew CCBHC in 2027. It's not my decision. If they don't, we'll have to deal with it. If they do, great, we'll keep going. Because it's a whole demonstration project. The whole state could end. They could say, never mind. I doubt it, but they could. The Trump administration could say, never mind. That's more probable than the state doing it.
Are other states doing CCBHC programs?
Yes. Yeah. It's a nationwide thing. So that's the contract. Yeah.
So there we go.
You
Is
need
there
a
a
motion?
Yes.
I move approval of Exhibit B list.
Moved and supported. Any further discussion? All in favor, please indicate by saying aye.
Aye.
And opposed, same sign. Thank you. That motion is approved. And Nick,
Yeah.
looking at end of interim financial statement or attachment C.
Now you'll see why I had that lengthy discussion at the beginning.
I feel like Michael's.
Yeah.
But the context was needed, right?
Yes, for sure. I appreciate it.
Yep.
So taking a look at attachment C, this is once again an updated amount as of September 30. This report was ran on the 11th, so we could send it out to everybody. So since the 11th, these numbers have actually changed as well. So just something to keep in mind. We added a couple notes to the top Medicaid fund, just for some knowledge for everybody. Looking at the Medicaid Healthy Michigan, the 2 deficits there are now going to be a part of our cost settlement with the LRE. We have our COPR agreements, grants, and other revenue. This is all stuff that we're expected to receive some of this funding yet. It's just delayed either from the state, from the insurance agencies, and from other counties. Looking down at the specific CCBHC portion payments, we have not received our September payments. I actually got a notification that we're getting a September payment for the CCBHC. So as you can see, we're still a moving target. But all of those as of today, we have not received the September payment. So that's why there's deficits for those.
Yeah, a couple months behind all the time. We have no predictability when our revenue gets us and when we get it. I know, you wouldn't run a house that way.
Now,
I mean,
I have a question about CCBHC, and I don't know whether it's even possible. If I ran a business and I had 4 product lines, I'd like to know for each product line where I was in income and expense to see if I'm running this particular product at a deficit,
Right.
or if it's profitable.
Yeah.
Is there a way for us to equate actual expenses for CCBHC versus actual income for CCBHC? And I realize there's a lag. We provide the service, we have the expenses this month, but we have to submit them, and then it may be 3 months later, we get reimbursed for them. But is there a way we can book that as, receivable and include it in a P&L or a balance sheet so that we have some idea? Is CCBHC worth doing?
So any of the CCBHC, what I'll tell you my knowledge of it right now. So any CCBHC payment that we receive for the actual month that it's paying for, we book it back to that month.
Yeah.
So when we run the expenses within that month, we can look at what the revenue that we actually received for it. So when we get the September payment, if it comes this week or next, we'll actually book that back to September so we can verify, okay, this is our CCBHC expenditures based on these programs, and this is the revenue that we received from it.
So, but by February or March or April, all of that will be settled. And at some point, will we be able to look at CCBHC as an entity and say, for this past fiscal year, this is the end result? It cost us money,
probably.
or we made money.
Probably
or we-
January of the year. Like, it literally takes that long for everything to, that's the point. It's not the November surprise. It's what actually happened. You'll know by January.
Yeah.
Even though that's happening, but that's part of that new forecasting stuff we want to put in, because the reality is we're at full risk for all those expenditures. So we have to be able to make that determination eventually, like, can we keep doing it? Now, the good news is that we do get that quality bonus every year. And, being able to use that quality bonus to offset expenditures. And we didn't even know what our rate of reimbursement for this was going to be until lately. We've been monkeying around for almost a year. What's the extra payment rate going to be? And we had discussion for literally 7 months with the state before we could predict what the revenue is. In fact, we thought it would be this amount, and they say it's going to be this amount, right? And we're like, well, all year we've been assuming this amount. So it will get clearer, but we will have to do what you're saying to see within the margin of error to run the program, because we're at full risk for it. There isn't a reserve fund to offset that balance. There's only local dollars, county general fund, millage, or fees, or something else we have. So if we overspend on CCBHC, there isn't a fund ISF for that. And so that's why your comment is needed. But I will tell you, we're on our 3rd manual with that program, the demonstration project, and on our at least, and I'm not exaggerating, 10th different version of how we're supposed to complete all this. And I think we're finally getting to some resolution, and then the state changed the way they did the whole thing. Instead of working with the PHP, now you're directly going with the state, and they still haven't figured out everything. So the answer is we're gonna have to, Tom. We don't have all the components yet to comply to your basic request. And that has to be developed within the next quarter, or we won't have any predictive analytics. We now have some new dashboards we're using, which will show that say, here's the amount of encounters we need just to meet the estimated budget we put out. And that's just been developed and projected. And now we're looking at those targets are right, so that staff know we have to have X amount of visits, or the DCOs need that, or we're not going to break even. We got to put all those in place with a moving target.
Now, the other part of that is, let's assume, for the sake of argument, we have that data, and we can then analyze last year at some point in time and say, what happened with CCBHC? Was it self-sustaining? Did we lose money? Did we make money? If we made a profit, wonderful. We get to keep that and use it for other expenses. If we didn't make money, if we lost money, how do we pay for it? Do we use Medicaid dollars to do that?
No.
So where does the money come
It
from?
comes from local funding, either county GF, millage or other local fees that we collect are the only sources, or a donation by somebody, that would work. But it's one of the issues the counties have. Can they use county general fund dollars to cover CCBHC losses? This program was never conceptualized in the context of a county department, really CMH authorities. So I don't think anybody thought that through, that county government might not be able to use county GF to offset that. I think they possibly could, but we're talking about that. Like, how do we balance it within a county department structure? But the answer is you cannot use Medicaid. That's the point.
Now, the next question is, we get to that point where we have to make a business decision. Do we continue CCBHC or not? If we were to discontinue CCBHC in this fiscal year, had we done that, what would the impact have been on our operation? We still would have had people who received services under CCBHC who we would have had to serve under straight Medicaid.
Right.
So somewhere in here, we have to balance the benefit to the Medicaid program by having CCBHC for offloading some of our costs to that program.
Right. And I run this for a living and I get a headache thinking about it, right? So like that very statement is true. The cost benefit analysis will have to be done, right? But here's the rules with CCBHC. According to Manual 3.0, I don't know if it'll be the same. If we self-select out of it, okay, we have to go an entire year keeping the services for those people in place without any extra payments. It's the penalty for it. So you can't just go, oh, we're done. And then all of a sudden they go, okay, you're done starting in 2 months, and just notify the people. They're like, you got to maintain the whole services you're giving those people for an entire year before you can get off of it. And they won't give you a PPS1 right on top of it. So you lose your shirt that year unless you can go the other way quickly and say, this is really a straight Medicaid person, don't, but they know that too. The data's in there. No, I don't think anybody's dropped out yet. I think there's one thinking about it, but that I know of. It's one of the reasons why a lot of the northern CMHs haven't done this. They couldn't stand up mobile crisis 24/7. Nobody can really. And they just like, we're too small to deal with this. I think I'm a lot more optimistic than I used to be about this program. When I first got here, I'm like, I don't know what the heck, now I understand some of the value, but you would have to do the cost benefit analysis. Now, luckily for us, and Anna, you get credit for this, we didn't overexpand to the moderate population. We kept it to mostly and at first I'm like, we didn't even expand it, right? Now I'm like, we didn't expand it, right? Because if there's a change or an unwinding, we're just dealing with that. And we're not dealing with general fund issues. So right now, a lot of CMHs expanded CCBHC, and they don't get an extra payment for anybody that's general fund, only the Medicaid folks. But the program assumes that you'll take general fund folks in, right? And then you're going to have enough extra revenue to cover the cost. Isn't the case. Everybody's losing their shirt on the general fund side. So much so we're asking, what should the benefit be different? Right? So luckily we didn't overexpand to other population groups, which I used to be critical of. Now I am very thankful for. And now that we're there, we have to kind of figure, does it make sense? Because we won't be able to sustain a huge hit on the local fund side. If we see that several years in a row is a huge hit, we'd have to do it. We have some millage we could use in reserve, but that's about it. So does the benefit outweigh itself? And that will be a decision based on data that this board will make.
Now, if DCH persists in recontracting out the PIHPs to the 3 PIHPs, who bears the liability for the CCBHC program?
We 100%. We 100% now and 100% then.
Even then.
Even then. So the PHPs have been purposely cut out of the process. So we already started no PHP involvement in this at all. They used to send the money to the PHP and they sent it to us. Now we get it directly to the state. Some of it, personal belief, is staging it so that when all PHPs are regionalized, they've already done this, right? But no PHPs will ever be in the business unless they change it and dealing with CCBHC as a pass-through or anything else. And it's created quite a mess because half those folks are Medicaid people that we'd see anyways. So when there's an eligible service and non-eligible service, it's confusing. Appeals, Medicaid appeals, we're dealing with that right now. So the state has set it up where CMHs or non-CMHs that are CCBHCs, a couple of them, have no relationship with the region, the PHPs at all, starting last October. And we're still figuring out how that works. Pretty convenient, huh? They're completely separate.
All right, down to the expense portion. We have now labeled anything that is within our CMH control, just for some better knowledge for everybody.
Right.
Looking at the specific categories within our control, where you can see we have the actual reduction of expenses, as Michael mentioned. So salary and benefits, $677,000 off our budget, $118,000 versus or for internal contractual services. So that's stuff that we utilize for operating our business, not specific to client care. Looking at client care, we're $1.5 million under our expenses. So this is where we added the $3 million specifically to in October. So as you can see, of that $3 million that we added, we have now spent about 1.5 million. Looking down at the SUD, kind of similar situation. So we have the salary and benefits where we have reductions as well as supplies and other. And yeah. With that, any questions on the 222 fund at either revenues or expenses? Jumping down to millage, as you can see, we have a lot of under budget accounts as well. In relation to the revenue portion, all of our grants were submitted on October 30th. That is the deadline for our fiscal year 2025 stuff. We have started to receive payments. So that 763 should be reduced down by almost all of it, based on our expenses. And then everything else is with under budget for all expenses, regardless of its millage or grant for the year. So controlling what we can control.
Great.
All right, have we met, Myra?
No,
I didn't think
I'm
so.
sorry.
I think this is the first time I attend.
That's what I thought, well,
Myra, I'll let you introduce yourself.
Good afternoon, Myra Ocasio. I'm actually the Assistant Director of Fiscal Services. I normally work up in Fillmore. And I'm just filling in the financial manager role until we fill the position. So I've been down here for a little over a month now, just trying to, help out as much as I can, fill in where, wherever Amy was doing, which is sort of like all the reporting to the LRE and things like that. Nick and the team take care of most of the day-to-day stuff, so.
okay, thank you. Thank you
Yeah,
for
he's
jumping in and helping.
Absolutely a godsend. Great.
So so this is one of the reports that, reports to the LRE, which is the interim financial reporting that Amy was taking care of. And, we have contracted with Amy to do the fiscal year 25 reporting. So she's, kind of gathering all the data, and we're working with her to kind of finalize it, and then we submit it here on the CMH side. And this is a reflection of what Nick went over on a high level, but just Medicaid as far as what they're projecting. And now these numbers are slightly different than the report that Nick just went over, because this was pulled probably about a week before he pulled his, because this was due early, sooner than the information went out to this board. And you can see where we have a deficit that we're showing because of what the LRE has projected. that the revenue is for Medicaid for us versus what our expenses were for those Medicaid services. This is projecting, I think, about a 4.9 deficit, which you can see in some of the numbers that Nick just mentioned. But of course, it's still fluctuating. We're still, processing a lot for the end of, fiscal year 25. For Medicaid and for CCBHC as well, we have still a lot of encounters getting processed through PC.
And when you look at this report, please realize the other CMHs that were listed here didn't have all the data in. So it looks like Network 180 is a surplus. They have like a $15 million deficit.
They haven't submitted.
Well, no,
Well,
they have, but this is the form. Everyone submits, each CMH submits, and then they put it on their spreadsheet, and you can see, like a column for each one. We don't see that, obviously, because they send it all to.
Okay.
yeah, so it's not a reflection of where they're at. Is what you get at.
We'll see it at the end, once
Yeah.
everyone.
And you see it like also on one of the other attachments where it says Network 180 had $187 million. Good, that's not true. So just know that's our data we're looking at.
They don't have their expense numbers. in
Yeah,
there, so they
yeah,
look-
none of them do yet.
Okay.
They look great. I'm like, wow,
Yes, I know.
everybody's 100%.
Wait,
Can we do that? Just not report expenses?
Yes,
You know,
people do that all the
don't-
time. They
we
just
don't
put
get any
due
money, so-
by the LRE and they just balance it out.
Which we will end up doing at the end of the year.
Yeah.
Once we finalize everything, and I
Yeah,
mean, we will be within that,
in that window. Yeah.
percentage to use the ISF, and then we'll look at do from the LRE and then make our revenues whole to our expenses. But that won't be happening until
Wild.
December.
Yeah, if you're lucky. And I attend, just so if you're on the LRE board, if you personally address the LRE board and explain our situation, which has not been done by another CEO on this stuff. I tend to go there and do that. Here's what we think, here's our plan, those things. Mhm.
thank you for that explanation and welcome to the meeting here. We
Yeah.
appreciate you. So I think we're at the point where we're ready to entertain a motion to approve. Of course, what Myra just went over is for information only, but we would like a motion to approve the fiscal year 2025 interim financial statement as presented and forward to the full board. Moved and supported. Any further discussion?
I have a question. We are asking the full board to approve the financial statement. What does that mean?
What does that mean in terms of?
We received a financial statement.
Mhm.
It means we're in agreement that it's accurate or reflects the state of the agency based on this point in time.
Mhm.
But is there any repercussion beyond that by saying we approve the financial statement? The option would be we receive the financial statement.
Yeah. I like that wording better.
Mhm.
That, I mean, you could flesh it out more if you wanted, and you could say, received financial statement and approve it as, if you want to say approve. And agree that it's a reflection of the current financial status as known.
Mhm.
Adding the wording.
Yeah, if you
Um,
wanted more words to it.
Yeah, I think so,
Yeah.
because there are other people, this is not like approving our budget.
Right,
This is approving the receipt of,
right, exactly,
as we know it, this second.
right. So it could just be receive and enter into the record.
You can make that motion.
Okay, as I think about that. Why would we need to do that? Why would we need to why wouldn't we just say we received it for information only?
Yeah.
Yeah, that's totally fine.
Do we even need to
Michael, you need an opportunity to talk to the board about the moves that you're making.
Oh, I'll do that, regardless
You
of-
can do that anyhow.
You bet.
Yeah.
Okay,
It's called the director's report. I can talk about anything I want.
okay, all right.
So I guess I just think historically, it has always been, we approve the financial statement as it was presented. We're
Mhm.
approving that we received it as it was presented, but do we need to? Or could it be just for
You can-
information?
It can be
you do
information.
Financial statement as it stands today.
Mhm.
There's no requirement that you have to approve the financial statements that way.
Mhm.
It's kind of, it reminds me of when we have like yearly reports from departments and stuff like that, and they submit a report.
Mhm.
But that really we're receiving it. We're not
Right.
really
Mhm.
able to say 100% every word is accurate.
Yes.
You know, so
Mhm.
that, do you feel that the motion then needs to be this consistent here and then, at the meeting on Friday? So do you want? What's
Well,
that?
You might want to review the mental health code because I think in a quick search.
It might tell
so
us
just
what we
take
have
that
to
with a grain
do.
of salt. It does say that the code mandates CMH boards are responsible for oversight of financial operations, including review and approval of budgets and financial statements.
Yeah, and
Caveat, that was all from a search. So
Yes.
I have not
Yeah.
gotten into the mental health code.
So we
with that.
can, we can review it pending approval.
Well, it's financial statements, but I don't think it means the regional financial statements.
no, but, and
This
we,
is
we're
the
talking
CMH
about-
boards, right?
and we could potentially keep the verbiage
Mhm.
right now today
Mhm.
and then figure out for Friday or in the future if we can or should change the verbiage.
Mhm.
Because it's okay to have the verbiage be one thing here and change at the full board if need be.
Yeah.
So,
Are you asking that because of this particular financial statement, Tom? Or are you just asking this as a matter of practice that we have had in place for quite a while?
Yes.
Either or, pick A or B.
I guess I'm just one, if I vote yay, what am I voting for? And what is the consequence of that? I agree that, yes, I've received the financial statements, I've
Has been
discussed them, reviewed
explained.
them. My questions are answered. I think it's reasonable to present it to the board as an accurate financial statement with whatever caveats anybody wants to put
It's a
on it.
living document. It's organically
is.
changing all the time.
Yeah.
Totally.
It'll be different
And
on
it's
Friday.
presented that way when we present it to the full board.
right.
So I guess if this is something that you as a committee feel that we need to look at, that's going to take maybe a little more time than today.
Mhm.
Let's talk about people's level of comfort with moving forward with this motion for the next board meeting, knowing that there are some questions procedurally, if it is something that we need to approve. So are people comfortable moving forward with this motion?
I
We would need to hear what.
I think the motion was just to approve the fiscal year 2025 year-end interim financial statement as presented and forward to the full board with a recommendation for approval. So that's the motion that we're at this point. I'm comfortable with moving forward with it. We can also check the county because we're also receiving statements like from the treasurer. And it seems pretty similar, so
Right.
we can check that verbiage too.
Okay.
So,
Okay,
are you good with that?
all right. Then, the motion is on the table. All in favor, please indicate by saying aye.
I,
And opposed, same sign. Thank you. That motion carries. General information, comments, and meetings attended. Anyone have anything for that? Then we'll move to public comment.
Hello, Krista Mason, Benjamin's vote. I'm also going to read this public comment at the LRE meeting on Wednesday. Since 2018, Ben's Hope has received no rate increase. Instead, during this time, millage funds have filled the gap. Since 2018, our labor costs have risen by 70%. We've been informed that we will no longer receive millage funds. And today, while corresponding rates have been discussed, no rate increase has actually occurred. If rates were to remain unchanged and we lose the millage funds, we are facing a $327,500 reduction in revenue. This represents a 23% reduction in funding for our current Ottawa residents. 4% sounds nice.
Right.
This is an unsustainable reduction. The mandate that governs our work together with the Michigan's Mental Health Code requires that priority be given to individuals with the most severe forms of serious mental illness and developmental disability. Currently, we serve 16 individuals from Ottawa County. By January, we will be serving 19 Ottawa residents. The individuals who live at Ben's Hope live with profound and complex support needs. They are precisely the population the state requires to be prioritized. I need you to understand the gravity of this moment for us as a provider. I have been asked to consider how many and which residents I can no longer afford to serve from Ottawa County. To slow this financial bleed, if nothing changes, I will need to discharge the residents who require the most care. This feels like Sophie's choice. I'm asking you, this finance committee, to grapple with the same question that I have been asked to confront. How, under these conditions, do you propose that we uphold the state's mandate to prioritize those with the most serious need? Thank you.
Thank you.
could I ask a question for clarification? Christy, you said you have 3 new residents who are from Ottawa County who are joining.
Correct.
Will they be coming in at the old rates or the new rates?
The new residents, those who have come already, and the ones that will come yet, are coming in at appropriate rates.
And you have how many residents total there?
So currently we have 16 Ottawa residents,
A total on campus?
34.
And the other residents are you receiving a higher rate than Ottawa County is paying?
Yes, with the one exception being Network 180 due to their 5% rate cut. All of the other residents are at significantly higher rates. And may I expound?
Sure.
Yes. Part of reality, if I only look through a financial lens of how do we ensure the sustainability of Ben's Hope going forward, is replacing the underfunded Ottawa people with individuals from other counties who pay appropriate rates. I do want to say I'm very grateful for the work we've done with Dr. Brashears and his team to identify what appropriate rates would be. But honestly, it's just conversation if they're not implemented.
Krista, of those non-Ottawa County residents, how many of them are represented by other CMHs in the LRE? All of them?
But there are 4 individuals that are outside of our.
Outside of the LRE.
The rest are all LRE.
Thanks.
So we're receiving better rates from our partners in the LRE.
Thank you.
It might be helpful for that public comment or that information to reach the entire board
Sure.
by email, or if you could come back.
It's Friday, right?
CMH board.
I'll be there.
9 a.m.
Yeah. Would
Thank
you
you.
like me to incorporate your questions as well?
Sure, sure.
I only have one question for you.
Yes.
You're less than 3 miles away from here, right? This is our county's
Yeah.
resource.
They really are our people.
Mhm.
And that's our charge.
Yeah,
Mhm.
yes, totally. Thank you. Any other public comment? Anyone online?
Actually, I do have one further question.
Tom's out.
Yeah.
A couple of months ago, we had a gentleman who came to the board meeting, who's in his 90s, presenting the dilemma that he has a son he's cared for all of his life, who needed a placement to ensure continuity of care. And he's now, I believe, at Benjamin, so and he has the newer rate.
He does have the new
Great.
rate.
Okay.
Yes.
What if we took all of the other 16 residents and had them leave Ben's Hope one night at midnight and then apply for reappointment the next day at the higher rate?
What about that?
I'm turning red.
You didn't get that.
Well, yeah, I don't know.
I'm open to any ideas.
You guys, this is just easier to increase the rate.
Yeah. But it's, the word you used before was equity.
It is
As much
equity.
as that makes my skin crawl sometimes. Equality is maybe
Yeah.
a better word.
You know, other providers who have threatened discharge or have actually discharged.
Yes, they
in order
have.
to leverage different rates, and that just feels like using a person as a human pawn.
Right.
Especially
Yeah.
a person with responsibilities as a human pawn. And our values just wouldn't allow us to do that. Just to get rates.
Right. And you know, and our Harbor House partners went 10 years without a rate increase. So
It's a
Thank you.
dilemma.
it is, we're gonna solve it though.
Are we, I know we're kind of going off on a subject, but are we mostly bound by our LRE? Reimbursement
No,
rates, or
yes.
what are we bound by?
Our budget alone,
The budget?
revenue. It's really that simple. If we had the revenue, no one would care if I'd increase their rate by 50%. They'd go, great, man, you're a good CMH if you balance your budget. That's it. Not what do we have to do, right? So if we had the revenue, we would increase the rate. And my thing is, I'm supposed to prioritize the budget by the most severe. And when you're underfunded, this gets to be really a challenge. And so that's why we're looking at all the things we control, all the things we don't. But there's no other way to go besides raise the rate. Just my belief. I'm not going to use millage to deal with a Medicaid problem.
Michael,
And the question for the LRE is are we partners of our?
Yeah.
Yeah, and they got more revenue, they gladly give it to me,
Yeah.
you know, so it's getting that revenue.
what if the cost of balancing your budget would be going to everyone in the system saying everyone's rates are going to be reduced in order to provide enough revenue to balance the budget? I mean, if there is in fact a requirement for you to operate this agency on budget and not create a deficit, that's the only tool you have left in the book.
It is, but luckily we're in a shared risk model with the region and the state. If I was at full risk, we couldn't have this conversation.
Yeah, but shared risk means now if you deem it's necessary to raise everyone's rate, you're permitted to do that.
I am,
And we
as
are
long as there's
ready,
cash flow to pay people. I had to look at my, for that one.
just thinking about the deficit we have already encountered. How are we deciding that raising a rate is not a legitimate reason to go into
Yeah, to me,
deficit?
it's gonna sound like a very simplistic answer,
I would like that.
okay? We are determining services that are medically necessity, have medical necessity, and then determining what the cost of care is and adjusting the budget based on that. So it's not a matter of, I know this sounds completely counterintuitive, the amount of money you have. It's what's medically necessary and what does it really cost? And then getting that number so that the region has it and the state has it, because we're in a shared risk model. No one wants to increase the deficit to $8 million, especially the region or the state. But I'm only on the hook for a portion of that, not all of it, in a shared risk model. And somebody has got to tell the state in an agreed upon method what the actual cost is. So the way I'm doing that is ensuring first that everything is medically necessary and we have the tools to support it under law. I can't tell you how many fair hearings that we've sent Anna Bednarik to try to explain to a judge how we determine that. And because the state keeps changing the tools we use, it's hard to do. So we're doing that. With residential, it's not as complicated, but we had to literally create a level of care model ourselves because no one would do it. We did it, costed it, validated it with research. And then that's when I can even justify coming to anybody saying I'm increasing. But really the simplistic way is determining that the service is a medical necessity and that the cost to deliver them is within a reasonable structure. And it's that second part that's more difficult. You know, there are federal procurement laws that say we're supposed to meet with every contract provider every year and ask them, are we covering the cost of care? It very rarely happens. CMH is to say, here's what you can get or not get this year. You're supposed to meet with them and go over what's allowable, what's not allowable. It takes a very long process. But it's about, are we getting enough revenue to cover the medical necessity and cost that we all agree on? And what can we control to help limit our budget? And that's why when I started putting things in our control or based on client care and making sure our utilization management piece is right on, so no one can question. People have already accused me of meeting with residential providers. I'll say it in public, just to give my buddies money. Oh my God, if that's the case, I would have increased the budget on month 2. Right? I went through a very rigorous process to determine this. And I wish this was the only area, but we need it replicated regionally and the state needs to do it. And we intend, the region is supposed to help me with this, in January, after the holidays, to go to the state and say, look at all of these residential expenditures. We don't think it's in our rates and start fighting them for more revenue. Because they take all the surplus Medicaid around the state and they kind of move it around too. So the answer really is medical necessity and determining the real cost of care before we even get to what the rate should be. And it's a lot of work.
I think you have one additional problem too, and that is no one's paying attention to it.
Right.
So somehow you need to figure out a way to make the state care.
Yeah, they're into, we're gonna one of the reasons why you restructure it, you move all the Medicaid back at the top and you start over. Every single time there's a problem, we go from 18 PHPs to 10 to whatever. It's like, we can't manage it. I know what we'll do. We'll shrink the number, throw all the Medicaid up and start over.
And the problems don't get solved. For
No,
another 5 to 10
because the
years.
simple matter is our benefit in Medicaid is really rich. So if you're not going to deal with what is offered, then you have to deal with the real cost of it. We have a lot of services that a lot of states don't have. Now, I like that, but it's a pretty rich benefit. And so can we afford this much or do we need this much? Right? And the state has to do the heavy lifting. Some of their reasoning for restructuring is to address some of this issue. It really shouldn't matter. It shouldn't matter where you live. You should have the same service and it should be relatively offered in the same way. I wish that was true. It just is not. I wish it was.
And 2 people living in the same group home with the same needs
Relatively the same, yeah.
should be reimbursed the same rates.
Right.
And the dilemma we have now is you have justified paying rate B to a consumer at a group home when consumer A, similarly situated, is reimbursed less.
Right.
So the question is, if you are right in paying rate B, then you must pay rate A.
Right. So here's my thing. When you meet with providers and you say, what is the actual cost? We actually came up with a methodology to agree on all the terms. And I say, yes, then we got the region to agree with exactly the same terms. Because how you define how much it costs is how you view the services. Some CMHs view the services just a personal care and CLS that are direct provider, like a aid does. There's a lot more that goes into that. Some you can't use Medicaid for, some you can. So we had to get like the operational definition consistent and then apply your A-B logic. I've already done it with new clients. So yeah, your theory of discharging everybody, great, you just gave them a way to do it, right? Discharging everybody, I've already got a methodology for new clients coming in. We're not going to go backwards. And we're really, it's not like we have 100 people coming in. And even when we did the emergency rate increase for Harbor House with 30 people, I didn't use the full rate that I could have with them. We got enough to cover their need because they're still not even funded at the rate that the rate calculator would. But they're like, okay, we're at least not moving backwards anymore to closure. So even though we increased their rates, we did it enough to cover the issue. And now we're looking, because I wanted to treat them the same as everybody else. Because if I don't, guess what? Everybody says, if you don't pay me by tomorrow, we're all discharging. We're going to go under. And some providers, all of our providers have a lot of ethics when it comes to that. There are examples around the state where that's not the case. I do not feel like I'm being placed in a corner just to increase rates. I need to increase rates because we've kicked the can down the road so long. I'm now too much of an outlier, unless we want to use $4 million of millage every year to do that, which we could, but it's a Medicaid issue, right? So I know we kind
It's an
of,
authentic,
yeah.
it's an authentic conversation.
Yeah, and I'm very regimented with it. So it's kind of like, I don't exactly make them all happy when we talk, trust me. So it's doing what the client needs in a fair, equitable manner. But we're so far behind our rates compared to some of our folks in the region. It's not even apples to apples, it's apples to wrenches. And so that's the problem we have to make up in a short period of time because of the compounding stuff. And what we did with millage really did stabilize the network for years. It really helped, but it didn't solve the problem. But hey, thank God we did it. So you just can't continue the practice, in my opinion.
So I don't think we're gonna solve this one
No, I
right
don't
here
think so.
today. Good discussion and
Yeah.
no other public.
It's all Tom's fault, just so you know.
All right,
We
thank
get
you.
overtime?
Yeah.